Today we will be discussing one interesting case from cardiovascular system. So now I will be presenting the history of this patient. Okay, 24-year-old male by name X. Okay, he is a daily laborer. He is from Gulbarga district. He has studied till 5th standard, and the history is given by himself and it is reliable. Coming to the presenting complaint, breathlessness on exertion since last 1 year. That is the only presenting complaint. Coming to the history of presenting complaint, patient was apparently normal 1 year back when he noticed breathlessness on exertion for the last 1 year. It is insidious onset, gradually progressive. It has progressed from NYHA class 2 to NYHA class 3 during the last 3 months. It aggravates on walking, climbing up stairs, relieves with taking rest and standing still. It is associated with easy fatigability and not associated with orthopnea, PND, wheezing, or neither it is associated with platypnea and orthopnea. Why that platypnea and orthopnea history is important, I will discuss later. Why that point you should ask in this patient. So he has a breathlessness, insidious onset and gradually progressive. There is no history of orthopnea and PND. History of orthopnea and PND, as I discussed earlier, if it is not there, left heart is not involved. Orthopnea and PND, if it is there, left heart will be usually involved. That is a feature of a left heart failure. And he has NYHA grade 3, grade 2 to grade 3, the breathlessness progressed. As I discussed in the last classes in phalangostatology also, there are different ways of grading the breathlessness, like a specific activity scale, grade 0, grade 1 where you can do more than 7 metabolic equivalents, and grade 2 more than 5, grade 3 more than 2, and grade 4 less than 2 metabolic equivalents. And one metabolic equivalent is equal to 3.5 ml of oxygen per kg per minute consumption. And Canadian classification of the breathlessness, where the breathlessness, the grade 1, he will be doing on severe exertion breathlessness, grade 2 is more than 2 blocks he can walk, grade 3 is 1 to 2 blocks, and grade 4 is daily activities. 1 block is equal to 528 feet. And for respiratory breathlessness, as you know, you have modified medical research classification. Whereas grade 0 is severely breathless, grade 1 is hurrying on a level ground or walking up the hill, and grade 2 is he walks lesser than the peers because of the breathlessness, and grade 3 is less than 100 yards breathlessness, and grade 4 is daily routine activities. This patient doesn't give history of cough for last 1 year, so unlikely a respiratory cause of breathlessness. And even the left heart is not involved, there is no history of orthopnea and PND. So then what is the cause of breathlessness? Why is that? Let us see after the examination and after taking other relevant history, what may be the cause of his breathlessness, which is a chief complaint in him. The other complaint he had was history of fever 3 months back. It was there for 8 days. It was high grade fever, sudden in onset, intermittent, no aggravating factors and relieving factors, and it was relieved with taking medications. And the fever was associated with cough with a yellowish sputum production, and it was not associated with any joint pain, rash or weight loss. So this patient had a history of fever, probably lasted for around 8 days, last 3 months back, one attack, okay, and then it subsided with taking medication, and fever was associated with cough. Now coming to the cough history, cough it is productive, yellowish sputum in production. That is also 3 months back when he had history of fever, at that time only he had a cough. It was sudden in onset, gradually progressive. Initially he had 1 to 3 bouts, later increased to 5 to 6 bouts per day, and it was associated with yellowish sputum production, okay, and it is moderate in quantity. Not foul smelling, and aggravates with the fever, and cough also relieved with the taking medications. And there is no history of hemoptysis, there is no blood thin sputum, no history of sore throat or wheezing. So he had a productive sputum around last 3 months back along with the fever, which is yellowish sputum production. So probably he had a respiratory tract infection which was subsided with taking antibiotics 3 months back that attack. So when he had that fever and cough 3 months back, he went to a hospital, a local nursing home, where he was diagnosed as having a heart problem, and then he was referred to a hyacinth. So he gives history of easy fatigability since last 3 months. Along with that, he gives history of discomfort in the right hypochondriac region. That discomfort is insidious in onset, non-progressive, and it is not associated with any yellowish discoloration of the eyes, jaundice or any history of vomiting. But he has a discomfort in the right hypochondriac region along with breathlessness. So no history of swelling of both the lower limbs, no history of palpitation, chest pain or syncopum, other symptoms of cardiovascular disease. At present, there is no history of cough and fever. Only one attack here 3 months back. Last 1 year, never he used to have cough and repeated cough, which could explain the respiratory cause of breathlessness. He never had. No history of any wheezing or even bluish discoloration of the palms and so. Though there is no history of cyanosis or any wheezing also. Past history, there is no history of similar complaints. For example, he has a breathlessness at this young age, around 23-year-old. So, if there is any left to right shunt, now your doctor told 3 months back when he had fever and cough, he had a heart disease. So, left to right shunt, ASD, VSDs and PDS will have repeated respiratory tract infections. So, that history you have to ask, how do you define a repeated respiratory tract infection? If there is history of any tonsillitis or pharyngitis, more than 3 in a year, or if there is any rhinitis, more than 5 in a year. So, tonsillitis or pharyngitis, more than 3 in a year, or rhinitis more than 5 in a year, or otitis media 3 in 6 months or 4 in 1 year indicates repeated respiratory tract infection. This patient doesn't give that history. That history is important here because left to right shunt lesions, ASD, VSD, PDA will produce left to right shunt lesions, will produce repeated respiratory tract infections. Not a diabetic or hypertensive. And there is no past history of rheumatic heart disease, bronchial asthma, or thyroid or tuberculosis. The past history of rheumatic fever is important in this patient because rheumatic fever develops at 5 to 15 years of age group, where the severe joint pain they remember whole of their life. So, for a past history of rheumatic fever, you have to ask history of rheumatic joint pains. This patient doesn't give history of that. Only 50% will remember it. Usually it takes 15 years, 10 years to develop the rheumatic heart disease after the rheumatic fever. But in India, because of the virulent strain, it can develop very early also. So in India, even at 20, 24, even at 15, 20, rheumatic heart disease can develop after the history of rheumatic fever. No history of previously taking monthly injections, so he doesn't, because if it is established rheumatic heart disease, they will give history that monthly injection, penicillin they will be taking. Here there is no as such history. Coming to the personal history, he takes a mixed diet, there is no addictive habits, bowel and bladder is regular, sleep is adequate, and there is no high risk behavior. Okay. Now coming to the family history. Family history, he has no brothers, he is married, and he has an 8-month-old baby, which is normal, and there is no other similar complaint in the family. That is the family history. So now coming to the analysis of the history, student. Suppose if 3 months back, if the doctor has not told that he is suffering from a heart disease, what are the differential diagnoses you would have considered? A 24-year-old male was come with a breathlessness and exhaustion of his main complaint, no history of orthopnea or PND. Probably in India, one of the common differential diagnoses which we will consider is anemia. Anemia is so prevalent because of malnutrition that anemia can present with tiredness, breathlessness, easy fatigability. It's a possibility. The next differential diagnosis at this stage, 24-year-old, is a congenital heart disease. Which congenital heart disease can present at this age group? A PDA can present at any age group depending upon the shunt lesion, the magnitude of the shunt lesion. VSD, a moderately restrictive VSD, can present at this age group with the left heart failure and congestive heart failure, it can present. And ASD, usually in the 4th decade, they will come with the atrial arrhythmias, the palpitation, and depending upon the shunt lesion, it can manifest in the 2nd decade, 3rd decade, or 4th decade as a breathlessness. And one more important congenital heart disease which can manifest in the 2nd and 3rd decade is bicuspid aortic valve. It can present like aortic stenosis or aortic regurgitation in the 2nd decade. So, which are the diseases you will consider, student? Congenital heart diseases could be a bicuspid aortic valve, ASD, VSD, PDA. And one more thing is rheumatic heart disease is a possibility. He doesn't give the history, but as I told, only 50% will remember the rheumatic fever history in the childhood. He could be one of those, a possible rheumatic heart disease. He has a breathlessness, could be a mitral valve disease, could be aortic valve disease, is a possibility. So, with these things in mind, anemia, congenital heart disease and rheumatic heart disease, we can go to the examination of these patients. Because the ASD, VSD and PDA will have specific findings on examination and auscultation, which will examine if he has that, then we can conclude he is having that disease. Okay, these are the differential diagnosis, students: anemia, congenital heart disease and rheumatic heart disease. Now let us go to the examination, general physical examination of this patient. So students, now let us go to the examination of this patient. Okay, first come to the general physical examination. The patient is conscious and oriented. His height is 152 centimeters and weight is 57 kgs. Temperature is 98.4 degree Fahrenheit. Pulse is 88 beats per minute, regular, and the normal volume in character. There is no radial or radiofemoral delay. and all the peripheral pulses are felt normally and the vessel wall is not thickened. Coming to the blood pressure, the right arm is 128 by 80. Okay, the left arm is 130 by 80 and the left leg is 140 by 80. This important checking the blood pressure in upper limb and lower limb because the one congenital heart disease is coarctation of aorta where the blood pressure in the lower limb will be lesser compared to the upper limb. So you have to take blood pressure in both upper and lower limb. Respiratory rate is 22 cycles beats per minute and it is abdominal thoracic. Now coming to the examination of pallor. Upar dekhna. So there is no pallor. One of the differential diagnoses which we thought in this case is anemia, which could explain the breathlessness, but he is not having pallor. No jaundice. Niche dekhna. There is no jaundice and there is no cyanosis. You can see he sleeps. There is no cyanosis and clubbing. Clubbing. So there is no clubbing, students. Here you can make out there is no clubbing. Lymphadenopathy. You have to go from behind and you have to palpate the lymph nodes. There is no lymphadenopathy. Then edema. So now I will demonstrate how to look for the edema. Okay. So here you have to press above the medial malleolus, just 5 cm above the medial malleolus for 30 seconds and there is no edema. Students, in this case you are thinking congenital heart disease, ASD, VSD, PDA. So when you are thinking these congenital heart disease, some physical features you have to look from top to bottom, some of the syndromes. Which are syndromes which are relevant in this case? The common syndrome which is relevant in this case is Down syndrome. So the Down syndrome features whether he has a slanted palpebral fissure. Slanted palpebral fissure will be like this. The medial will be downwards, the lateral will be upwards. So that you have to see. Or any flattened nasal bridge is there you have to see. And the angle of the mouth will be sagged down and macroglossia will be there. And in the iris there will be brush-filled spots. Brush-filled spots is the whitish depigmentation in the iris surrounding the pupil, the brush-filled spots. And one epicanthal fold of skin. In the here in the medial part of the upper eyelid, there can be one extra fold of skin. There can be epicanthal fold of skin. So epicanthal fold of skin, the slanted palpebral fissure, the depressed nasal bridge, macroglossia, both the angles of the jaw sagging, okay, and then single palmar crease in the hand. Whether any single palmar crease is there, you have to see. Here there is no single palmar crease. You have to look for a single palmar crease. And then in the foot, there can be a wide distance between the great toe and the second toe. Okay, this is the features of Down syndrome which you have to look. Next is Haut-Oram syndrome. It's one of the important syndrome in atrial septal defect especially. So what are the features of Haut-Oram syndrome? Haut-Oram syndrome, there can be an absent thumb. Absent thumb can be there. Okay. And then there can be a crooked appearance. Crooked appearance is the bend. The thumb can be bent like this. It can be bent like this. And there can be a triphalanx. Normally, this thumb has two phalanx. There can be a triphalanx in Haut-Oram syndrome. And then there can be an absent radius. The radius can be absent in Haut-Oram syndrome. Or abrachia. The hand itself can be absent. Abrachia. And phocomelia. Phocomelia is absent upper limb along with the maldeveloped hands. These are the features which you get in Haut-Oram syndrome. And then next go to the other important syndrome, Patau syndrome. Patau syndrome, so they have polydactyly. There can be one extra finger in the hands. There can be a polydactyly. Okay. And then cleft lip and cleft palate. The lip can be a cleft. The palate can be a cleft. And then they'll have a flexion deformity in the hand. Microcephaly. The head can be a small. And holoprosencephaly. Holoprosencephaly is the failure of division of the forebrain. There can be a failure of division of the forebrain. And single palmar crease like in Down syndrome they can have, and a low set ears like in Down syndrome they can have. This patient is not having any feature of Patau syndrome also and Down syndrome also. Next come to the Edwards syndrome. In the Edwards syndrome, the clenched fist will be there. The fist will be clenched like this. It will be clenched like this. The fist will be clenched like this. And then there are micrognathia. The mandible will be very underdeveloped and occipitum will be protruded. Occipitum will be protruded. Along with that, they can have a low set ears. So low set ears, the clenched fist, micrognathia and the occipitum can be protruded. These are the features of Edwards syndrome. Then Axenfeld-Rogers syndrome. Axenfeld-Rogers syndrome is autosomal dominant the kind of glaucoma in the eyes, maxillary hypoplasia, the maxilla will be underdeveloped, maxillary hypoplasia will be there, umbilical hernia, and then hypospadiasis in the urethra, hypospadiasis in the urethra. This is Axenfeld-Rogers syndrome. Next is Ellis-Van-Creveld syndrome, which is associated with common atrium. They will have polydactyly, the hand there can be extra finger. Then they will have clinodactyly. Clinodactyly, the fingers will be bent like this, clinodactyly, and then syndactyly. There can be a webbing of the fingers, So syndactyly, clinodactyly, and polydactyly. And the nails will be hypoplastic. In the hands, the nails will be hypoplastic in Ellis-Van-Creveld syndrome. He is not having any of those features. Okay. And then in the Ellis-Van-Creveld syndrome, there can be a multiple frenula in the upper lip. There will be a malformed maxillary incisors and gingival hypertrophy. So let us see whether he is having that or not. Yes, the dant. Karna is a karna. So there is no gingival hypertrophy. There is no multiple frenulum also in the upper lip. So that you will see. And his incisors are well formed. This is for Ellis-Van-Creveld syndrome. You will look. And the other syndrome which you will see is thrombocytopenia absent radius. For rubella syndrome, any deafness is there or microcardia. He is not having any microcardia and deafness. So those things also you will look. So which are the syndromes you will see, students? Down syndrome, the common. Patavo and Edward, the other trisomies. Ellis-Van-Creveld syndrome. Axenfeld-Rogers syndrome. Thrombocytopenia absent radius. Okay, and then rubella syndrome features. These are the features which you look top to bottom in this case. The other things which you look top to bottom in this case is any signs of infective endocarditis, like anemia is not having. In the hands, whether any osseous nodes is there in the pulp of the hands, you will see. Here there is no osseous nodes. In the pulp of the fingers, you will see painful nodules. And also splinter hemorrhages in the nails, whether he has any splinter hemorrhages in the nails, he is not having any splinter hemorrhages, that you will look. And then Janeway lesions in the hands, palms and soles. Here there is no Janeway lesions. So there is no evidence of infective endocarditis. Then in this patient also you have to look for any signs of rheumatic fever reactivation. Rheumatic fever reactivation, you look by erythema marginatum, which are the macular patches, and then subcutaneous nodules, the rheumatoid nodules. Usually you see over the olecranon process where the extensor part, where there is a more friction, okay, you look there for the rheumatoid nodules, and erythema marginatum in the upper limb skin, you will look for that, okay, it is not there for the signs of rheumatic fever activation. So these are some of the top to bottom examination which is relevant in this case. Now let us go to the examination, the cardiovascular system examination. And before going to that, JVP you have to always look. Here in this case there is no rise of JVP. Ideally you have to look in a 45 degree, the patient should be made. I have shown in the examination JVP part in general physical examination how to look and measure JVP. In this patient JVP is not raised. Now let us go to the examination of cardiovascular system proper. Okay students, now let us go to the examination of cardiovascular system proper. First, any precordial bulge is there, you will look. Precordial bulge, you look tangentially by looking like this. Okay, here there is no precordial bulge. And then you have to look for any apical impulse visible is there, you will look for apical impulse visible. Here apical impulse is not visible. And then you have to look for any visible pulsations in the epigastric region. There are no visible epigastric pulsations. Then any other visible pulsations in the left second intercostal space. This is the left second intercostal space. Here there are no visible pulsation in the left second intercostal space because the visible pulsation in the left second intercostal space indicates the more blood flow in the pulmonary artery, and in pulmonary hypertension you can get a visible left second intercostal space pulsations. Any visible pulsation in the suprasternal area you have to look. Here there is no visible pulsation in the suprasternal area. Okay, and then any scars and sinus if it is present, you will look. So what are the things you look in inspection? Any precordial bulge, because precordial bulge indicates the RVH before the onset of puberty. And apical impulse is visible, you will look. Any other visible pulsation in the epigastric region, left second intercostal space and suprasternal region, you will look for any visible pulsation. And then any other scars and sinuses. So here it is not there. So let us go to the palpation. Palpation, first you have to look for the apical impulse palpation. Let me palpate for the apical impulse. It's palpable here. So let me count. This is palpable here. Let me count the space, second space, third space, fourth space, fifth space. So in the fifth space, it is in the mid-clavicular line. Mid-clavicular line, just in the mid-clavicular line, the normal position is 1.25 centimeters medial to the mid-clavicular line. And the character here it is normal. It is just coming, touching and going, the normal character. The different characters, you know, hyperkinetic, heaving, the different characteristics of apical impulse. After apical impulse, then you have to look for any parasternal heave is there or not. How do you look for parasternal heave? With the ulnar border of your hand, you put your hand over the left sternum, ask the patient to hold breath in expiration. सांस छोड़ना इसी तरह रखना. Yeah, you have to look like this. I can feel the pulsation, but I can obliterate here. I am able to feel the pulsation, but I can obliterate here. So there are 3 grades of parasternal heave where it is visible but not palpable. Grade 2 is palpable but you can obliterate. Grade 3 is you can palpate but you cannot obliterate also. Grade 3. So parasternal pulsations are a heave you will palpate, and then any thrills is there you will see. By and large, the thrills in the apical area is diastolic. By and large, the thrills in the base of the heart is systolic, but there are some exceptions which I told in the examination of cardiovascular system. So let me feel for any thrills. Thrills are usually palpated with the base of the fingers. You use the tip of the fingers to localize the apex beat and the ulnar border and here and the base of the hand for a heave. So any thrill in the apical area I will palpate. It is not there, thrill is not there. Any thrill in the left parasternal, because we are considering VSD also in this patient. So left parasternal thrill is there, you will feel. And any thrill in the pulmonary area if there is a pulmonary stenosis. Thrill in the aortic area if there is aortic stenosis. So there are no thrills. Thrills indicates organicity of the murmur. It grades the murmur, grade 4, and it localizes the murmur. So no thrills. Next is any palpable P2 is there, I will palpate. Let me feel for the palpable P2. In the left second space, I will palpate for the palpable P2. There is no palpable P2. Palpable P2 indicates pulmonary hypertension. Pulmonary hypertension. So what are the things you see in palpation? Apex beat you have to palpate. Then you have to feel for the parasternal heave. Then any thrill is there in apical impulse, in the apical area, base of the heart, in aortic area, pulmonary area, you will feel for the thrill. And any palpable P2 is felt in left second space, you will feel. Then epigastric pulsations you have to feel. Let me feel for the epigastric pulsation. There is no epigastric pulsation. The 3 causes for epigastric pulsations is aortic pulsations, left lobe of liver, and right ventricle. As I told in the cardiovascular system examination, if the RV is enlarged, it will come and touch the tip of the finger. If the aorta is a pulsation, it will come and touch the pulp of the finger. And if left lobe of liver is enlarged, it will touch the left side of the thumb. Left side of the thumb. So here there is no epigastric pulsations. This is about palpation in this case. Let us go to the percussion. Percussion, you will percuss the base of the heart and the right side of the heart. Let me percuss and see whether it is enlarged or not. First, let me percuss the right side of the heart of the border. Second space, third space resonant, fourth space resonant, fifth dull. You can make out. Second, third, fourth, fifth is dull. When you get the liver dullness in the fifth intercostal space, go one space above, then come laterally, parallel to the sternal border. It is dull here in the right sternal border. The normal right heart border corresponds to the right sternal border. If it is away from the right sternal border, the dullness, that indicates pericardial effusion and aneurysm of the ascending aorta. This is how you percuss the right heart border. Now let us percuss the base of the heart. For that you will do a superficial cardiac dullness, light percussion. The normal cardiac dullness is present in the left third space. It is dull, left third space. This is normal. Suppose if you get dullness in the left second space, that indicates again pericardial effusion and pulmonary hypertension. So this is how you percuss the base of the heart. This is about the percussion. Now let us come to the auscultation. I will auscultate all the 4 areas. Then I will tell you the auscultatory findings to you. Mitral area. Tricuspid area. pulmonary area, aortic area, you have to auscultate in left first intercostal space also because you are considering PDA here. Gibson space. You have to auscultate left parasternal third fourth space because you are considering VSD. Okay, students. So auscultated in the mitral area, tricuspid area, pulmonary area, aortic area, also in the left first space because we are considering PDA in this case, and left third and fourth intercostal space because we are considering VSD in this case. So what are my auscultatory findings in this case? In mitral area, S1 and S2 is heard and there is no murmur. In tricuspid area, I am getting a mid-diastolic murmur. Let us see why that could be due to. And one more important thing in this case, what I got in the pulmonary area is the S2 is split and it is wide. And let me again check for the split with inspiration and expiration. जब मैं बोलता हूँ सांस लेना सांस छोड़ना, सांस लेना सांस छोड़ना, छोड़ना, लेना, छोड़ना. Yeah. So a split which I am hearing in the pulmonary area, it is fixed. Both in inspiration and expiration it is same and it is wide. This wide fixed split, students, this is the hallmark of atrial septal defect. This you have to remember. The hallmark of atrial septal defect is the wide and fixed split. And one more auscultatory sign what I got in pulmonary area is there is a ejection systolic murmur of grade 2/6 in pulmonary area in this case. In aortic area, S1 and S2 is heard, and in left first space, the Gibson space, there is no murmur, and then in the left third and fourth space, parasternal also, there is no murmur. So here there is a wide and fixed split of the S2, and why you get that? The wide split you get because P2 is occurring late, because the pulmonary capacitance is increased, and that because of that P2 is occurring late, that is why it is wide. And the hangout pressure between the descending limb of the pulmonary artery and the RV systolic pressure is wide, and that widening of the hangout pressure will decrease pulmonary hypertension. It closes and it is fixed both in inspiration and expiration. Why? Because the pulmonary capacitance is increased in expiration to the maximal degree and no more pulmonary capacitance can increase during inspiration. It is fixed both in inspiration and expiration. So what are the causes of a wide split of the S2? So wide split of the S2, A2 should occur early or P2 should occur late. Which are the condition? A2 will occur early, less blood flow entering the aorta. For example, in a ventricular septal defect, mitral regurgitation and ventricular septal defect, the A2 will occur early. Or else, even A2 can occur early if there is a ventricular premature beat or if there is a ventricular pacemakers are there. A2 can occur very early. Or P2 can occur late, for example, in pulmonary stenosis or RVP. Then the split will be wide because A2 occurs early, P2 occurs late normally, and the gap between A2 and P2 is 30 milliseconds, the normal gap. So if A2 occurs still early, P2 occurs still late, that will be widened. The split will be widened in these conditions. VSD, MR, LV pacemakers, then LV ectopics, or pulmonary stenosis or RVP. And here you get paradoxical split. That is P2 should occur very early and A2 should occur very late. P2 will occur very early in a ventricular premature beat arising from the right ventricle or a ventricular pacemakers, and A2 can occur very late, for example, in LVPB. So here there is a wide and fixed split and there is a ESM in pulmonary area. Students, you consider the other differential diagnosis VSD. There is no murmur VSD here in the left third fourth space, there is no murmur. So VSD is ruled out. And you consider PDA as the another diagnosis. So left first intercostal space, there is no continuous murmur which you get in PDA, so PDA is also ruled out. You consider anemia, patient is not having anemia, anemia is also ruled out. And then you consider bicuspid aortic valve. Bicuspid aortic wall, the hallmark sign is in the aortic area, either if you get a AS finding, aortic stenosis finding, or aortic regurgitation finding. In aortic area, there is no murmur at all, there is no ESM which indicates aortic stenosis, or no EDM which indicates aortic regurgitation. That is early diastolic murmur which indicates aortic regurgitation. So bicuspid aortic wall is also ruled out. And the hallmark sign of ASD is having the wide fixed split in the left second space, and also there is a ESM which can occur in ASD. So the examination findings fit into atrial septal defect. The other system examination is not having hepatosplenomegaly. The respiratory system examination is normal. The central nervous system examination is normal. So we can come to a diagnosis of atrial septal defect in these patients. So students, I just want to discuss a thorough detailed discussion about atrial septal defect after seeing the patient and examining him in him. There are 4 types of atrial septal defect. Ostium secundum, which is the commonest, 80 to 90%. Ostium primum ASD, where there is an endocardial cushion defect in the lower part, it is around 5%. And another 5% is sinus venosus ASD. There are 2 types of sinus venosus ASD. At the superior vena cava, where it comes and joins the right atria, there can be a defect there. Or the inferior vena cava, where it comes and joins the atria, there can be a defect there. Inferior vena cava sinus venosus ASD, superior vena cava sinus venosus ASD. And the very rare ASD is coronary sinus ASD. These are the types of ASDs. Usually, sinus venosus ASD is associated with partial anomalous venous connection. What do you understand by that? That means normally the pulmonary vein should drain into the left atria, but in sinus venosus ASD, the right pulmonary veins will drain into the right atria. So there is a difference between anomalous pulmonary venous connection and anomalous pulmonary venous drainage. Anomalous pulmonary venous connection means the veins will abnormally connect to the right atria. Anomalous venous drainage means the veins connect to the left atria only, but the blood will drain into the right atria. For example, sometimes the pulmonary veins can connect to the septum, near the septum, and then the blood can drain into the right atria. That is drainage. Then there is one more rarity known as the Schmittauer syndrome, where the whole of the right pulmonary veins will join the inferior vena cava and they form a Turkish sword like picture, and then they drain into the right atria. That is known as the Schmittauer syndrome. Coming to the history of atrial septal defect, usually ostium secundum ASD, the female is to male ratio is 2:1. Whereas ostium primum ASD and then sinus venosus ASD, there is gender equality. Males is equal to females. Ostium secundum ASD can be a familial. Then there are other familial ASDs like ASD with conduction blocks. Axenfeld-Rogers syndrome is autosomal dominant in inheritance. Oteram syndrome is autosomal dominant in inheritance. Then ASD with conduction blocks have a genetic abnormality in NKX 2.5. Fetal circulation is not at all affected by ASD because in the fetal circulation, the whole of the right side of the blood from the right atria enters the left atria through a patent foramen ovale. Pregnancy is very well tolerated, even they have conceived 3 or 4 times without any effect in atrial septal defect unless they have Asymmetric syndrome. Infected endocarditis is very rare in ASD students. For example, there is a connection between left atria and right atria, but still it won't occur infected endocarditis. Why? Because there is no pressure gradient between left atria and right atria. And theoretically, you expect infected endocarditis across the pulmonary valve because of the more blood flow, but that is also very rare. Till now, only 1 case has been reported of infected endocarditis in the atrial septal defect students. So pregnancy is also very well tolerated. The congestive heart failure is the commonest cause of death in atrial septal defect. Usually in the 4th decade, they present with the atrial tachyarrhythmias. Depending upon the shunt lesion, the magnitude of the lesion, either they can come to manifest in the 3rd decade, 4th decade with the heart failure, breathlessness. As the patient becomes old, the left heart will relax or distant ability is reduced because of the associated systemic hypertension, calcific aortic stenosis, and ISD and old age. The LV won't relax properly. And when it cannot relax properly, the more blood from the left to right atria enters, and there is a more increased incidence of atrial arrhythmias. As the patient becomes old, the pulmonary hypertension will develop usually. The pulmonary pressure increases. That will add a load on the RV over the volume overloaded. Already it is volume overloaded from left atria to right ventricle blood will be there, and more pressure overloaded by pulmonary hypertension. LV functional reserve is reduced in atrial septal defect because normally LV is ovoid shape and here RV is volume overloaded in ASD. That septum is shifted toward the left side, so the LV will become crescent shaped. So LV functional reserve volume will be reduced. The coronary flow volume also will be reduced in atrial septal defect because the RV is volume overloaded, enlarged, and the pulmonary trunk will dilate and will be pressed on the left main coronary artery. If the atrial septal defect is very small and restrictive, the flow between left atria and right atria is determined by the lesion there only of the restrictive ASD, which is very small. Suppose if the ASD is large in an atrial septal defect, at that time the left to right shunt is determined by the LV and RV compliance. Then one thing we should know about atrial septal defect is patent foramen oval. Patent foramen oval, the incidence is around 20 to 25%. It is usually associated with the increase in the transient ischemic attack and paradoxical embolism and veno arterial thrombosis and embolism. Veno arterial embolism, transient ischemic attack, paradoxical embolism, then decompression sickness, then orthodexia and platypnea. As I told in the history, that point you have to ask in this case why? Because patent foramen oval is one condition where it can be associated with orthodexia and platypnea. Platypnea is breathlessness in the sitting position, opposite to orthopnea. Orthodexia is saturation will be less on standing position. So this is about patent foramen oval. Now coming to the appearance. Appearance, usually their weight will be affected more than the height, so they'll have a gracile habitus, thin gracile habitus. They can have a Harrison sulcus because of the increased repeated contraction of the diaphragm, which will attach to the costal margin. They can have Harrison sulcus. Cyanosis is not a feature of atrial septal defect unless there is a Eisenmenger syndrome over the years. If pulmonary hypertension develops, if right to left shunt develops, they may develop cyanosis, or there can be a persistent Eustachian wall which will direct the blood to the left atria or common atrium. As I told in Ellis-Van-Creveld syndrome, there can be a common atrium with cyanosis. So students, cyanosis is not a feature of atrial septal defect, but there are some situations where you get cyanosis in atrial septal defect. One is Eisenmenger complex, where there is a right to left shunt lesions will occur because of the increase in pulmonary pressure, pulmonary arterial pressure. Common atrium, as I told in Ellis-Van-Creveld syndrome, they can present with cyanosis at birth. Persistent Eustachian wall, where the Eustachian wall will direct the blood from the right side to the left atria. Then unroofed coronary sinus. So unroofed coronary sinus, persistent Eustachian wall, common atrium and Eisenmenger complex. These are the causes of cyanosis in atrial septal defect. Then the other physical appearances, as I discussed in the history, all the syndromes feature whether he is having a, you have to look. I'll repeat again for the students. One is the Haute-Aram syndrome, where there is an absent thumb. Triphalanx of the thumb will be there. Crooked appearance, the bent appearance of the thumb. Absent radius. Abrachia, the hand, the whole limb may be absent. Phocomelia, absent limbs with the malformed hands. That is Haute-Aram syndrome. Down syndrome, which I am telling repeatedly again and again because that is very important. Slanted palpebral fissure, brushfield spots, flat nasal bridge, macroglossia, the depressed angle of the mouth, single palmar crease, Patavo syndrome, where there are polydactyly, flexion deformity of the hand, cleft lip, cleft palate, microcephaly, holoprosencephaly, low set ears, single palmar crease. Edwards syndrome, where there will have a clenched fist, micrognathia, prominent occiput will be there, rocker bottom foot, the calcaneum will be very prominent with the convexity. Then Axenfeld-Rogers syndrome, where there will have a glaucoma, maxillary hypoplasia, hypospadiasis and umbilical hernia. Then Ellis-Van-Creveld syndrome, where there will have polydactyly, clinodactyly, syndactyly, along with the nail hypoplasia, with a multiple frenulum in the upper limb, with a gum hypertrophy and a malformed maxillary incisors. Then TAR syndrome, chromocytopenia absent radius, and rubellapum with microcornea, deafness can be there. These are the syndromes probably which you have to look from top to bottom in the examination. Now let's come to the pulse. The pulse will be normal in atrial septal defect in spite of the LV volume is less, students. And the blood pressure also will be normal in atrial septal defect. JVP again it is not rise unless they go for Eisenmenger and right heart failure, and A will be equal to V wave. So only if the pulmonary vascular resistance is increased, there will be a rise JVP. The precordial movements and palpation. The apex beat will be occupied by the right ventricle. The right ventricle is volume overloaded, students, as I told. Blood from the left atria enters the right atria to the right ventricle. So right ventricle will be volume overloaded and it will be enlarged and it will push the LV. So apex beat will be formed by the RV in atrial septal defect. Because the more blood flow across the pulmonary trunk, you may get a pulmonary trunk palpable sometimes in left second intercostal space. There are no thrills in atrial septal defect, students. The gradient between LA and RA is very less in ASD, so you won't get thrill. And even you won't get thrill because the more blood flow across the pulmonary artery in ASD. If a thrill is felt in ASD, either it is due to a associated PS or a very large ASD. So these questions will be asked in the exam, students. You have to know causes of cyanosis in ASD, and if you get a thrill in ASD, what you will consider. So if you get a thrill in ASD, either associated PS or large atrial septal defect, you have to consider. Coming to the auscultation, the hallmark sign of atrial septal defect is wide and fixed split. As I told before, it is wide because the P2 component is occurring late due to the increase in the pulmonary capacitance and increased hangout interval between the descending pressure of the pulmonary artery and the descending systolic pressure of the right ventricle. And this hangout interval approximates or narrows if the pulmonary hypertension develops. And it is fixed both in inspiration and expiration. Why? Because the pulmonary capacitance is increased in the expiration and no more increase can occur during the inspiration. That's why it is fixed. And you get ejection systolic murmur in pulmonary area due to the increased flow across the pulmonary valve, usually around grade 2 to 3. And it won't be associated with a thrill in atrial septal defect. It won't be grade 4. So grade 2 to 3 ESM across the pulmonary valve. Because more blood flow entering from left atria to right atria to the right ventricle, a flow MTM you may get in tricuspid area. So all these three signs you got in this patient, students. So there is a wide fixed plate, there is a ESM in pulmonary area, and there is a flow murmur of MDM. Students, the atrial septal defect auscultatory signs I have given in an audio clip to you. After listening to this discussion, you listen to that audio clip multiple times. All of you download the Littman library, students, both for cardiac murmurs, cardiac sounds and respiratory sounds. It will be useful. Any number of times you can listen and you will be perfect. You don't have to wait for the patients to come to your hospital to listen to those sounds. I have also given wherever necessary a relevant audio clips. In this atrial septal defect, after the discussion, you will have an audio clip of ASD. You can listen to it. So what are the auscultatory signs? ESM at the pulmonary area, a wide fixed split S2 in the pulmonary area, a flow murmur across the tricuspid area. Now what are the investigations you do to confirm the diagnosis? ECG. ECG, the hallmark sign here is RB in ostium secundum will differ, ostium primum will differ, the ECG changes. In ostium secundum ASD, the ECG changes RBBB, incomplete RBB with right axis deviation. Whereas in ostium primum, it is incomplete RBB with the left axis deviation. So students, remember, in ostium secundum ASD, it is incomplete RBB with right axis deviation. Ostium primum ASD, it is incomplete RBB with left axis deviation. Here RBB name itself is a misnomer, students. Here because there is no conduction block, anatomical block won't be there. It takes a little extra time to conduct in the right ventricle because RV is elongated, enlarged and thickened. So it takes a little more time. That's why it is conduction time is prolonged. So it's a misnomer. So you get a right axis deviation in ostium secundum ASD. There will be a clockwise depolarization of the heart with a Q wave in lead 2-3 AVF. Whereas you get left axis deviation in ostium primum ASD with a Q wave in lead 1 and AVF. There will be a notching in the 2-3 AVF in the R wave in ostium secundum ASD called as croquetage. Notching of the R wave in 2-3 AVF, okay, it's called as croquetage. Whereas there will be a splintering of the S waves in 2-3 AVF in ostium primum ASD. Croquetage in ostium secundum ASD, splintering of the S wave in ostium primum ASD. In a sinus venosus ASD, the defect will be at the SA node, wherever the superior vena cava will come and attach the atria. At that point, there will be a defect. So SA node will be a defective there. So you may get and ectopic focus will be guiding the conduction there. So you may get a negative P waves in lead 2-3 AVF, negative P waves in lead 2-3 AVF in sinus venosus ASD. And sinus arrhythmia will be lost in ASD. What is sinus arrhythmia? Sinus arrhythmia means during inspiration the heart rate will increase, During expiration, the heart rate will reduce. This is a normal sinus arrhythmia. This sinus arrhythmia will be lost in ASD. Why? Because to occur sinus arrhythmia, you need a separate pulmonary and separate systemic venous circulation. But in ASD, the two circulations is different. There is a connection. So, sinus arrhythmia is lost in ASD. You may get the atrial arrhythmias in atrial septal defect in the 4th decade. So, ECG may demonstrate those atrial arrhythmias. And some of the atrial septal defect may be associated with conduction blocks. So, you may get a conduction blocks. So, these are all the ECG changes, students. RBB with right axis in secondum, RBB with left axis in primum, crochetage in secondum, splintering in primum, absent POS in 2-3 AF in sinus venous ASD, arrhythmias, blocks, and loss of sinus arrhythmia. X-ray features. Blood from the left atria enters the right atria to the right ventricle to the pulmonary artery. So, pulmonary artery, there is a plethora, more blood to the pulmonary artery, lung will be plethoric. So, pulmonary trunk size will be enlarged, whereas aorta is getting less blood because from left atria blood is coming to right atria instead of going to the left ventricle. So, aorta will be inconspicuous. And because the more blood enters the pulmonary artery, the right pulmonary artery will give appearance of the handle of a water jug appearance. And Smithard syndrome is where the right pulmonary artery will join together to form a Turkish sword-like picture which will enter the right atria. That will be associated with the ipsilateral lung hypoplasia and pulmonary trunk can be absent. I will show the picture of Smithard syndrome while discussing the ECGs and X-ray in the theory part. And in sinus venosus ASD, there can be enlargement of the superior vena cava. So, pulmonary trunk dilatation, pulmonary plethora, inconspicuous aorta, water jug appearance, and enlargement of the superior vena cava in sinus venosus ASD. These are the X-ray features in atrial septal defect. Coming to echocardiogram, the best view is subcostal view. You have to put an echocardiogram probe here. Subcostal view is the best view. And to diagnose sinus venosus ASD, which will be missed by the other views, transesophageal echocardiogram is the investigation of choice to diagnose sinus venosus ASD. Coming to the other 3 varieties of atrial septal defect, students, which are important. One is Luton-Becker syndrome, which is common in India because of the acquired rheumatic heart disease. Luton-Becker syndrome is acquired rheumatic mitral stenosis and congenital ASD. Because both occurs in a female, the female incidence is very high of Luton-Becker syndrome. If the ASD is very restrictive, it behaves like a MS. If the ASD is very small, it behaves like a MS. If the ASD is large, the MS signs and symptoms will be ameliorated. There will be a prominent A wave in the AV because of the mitral stenosis. RA, RV and pulmonary trunks will be dilated. And you get a ESM across pulmonary valve, how you get in a isolated ASD. The RV here will be enlarged more compared to isolated ASD. This is Luton-Becker syndrome. Then common atrium. Common atrium, where the left and right atrium there will be one chamber. It manifests with cyanosis with increased pulmonary blood flow in infancy. Common atrium will be having ECG features like a ostium primum ASD with the left axis RBBB with the left axis deviation, Q wave in lead 1 and AVL, and splintering of the S waves in lead 2, 3 AVL. Common atrium will be associated with Ellis-Van-Creveld syndrome, as I discussed the features of Ellis-Van-Creveld syndrome, polydactyly, clinodactyly, syndactyly, nail hypoplasia, multiple frenulum, gum hypertrophy, and ill-formed maxillary tooth. This is common atrium. The other variety is ostium primum ASD, which occurs in 5% of the patient students. On ostium primum ASD, along with the ASD, they will have a cleft anterior mitral leaflet wall, which will be associated with the mitral regurgitation. So, they will have a LV, which is hyperdynamic because of the associated mitral regurgitation. And you will get a murmur, mitral regurgitation murmur in a mitral area, which is conducted to the base of the heart. There can be a systolic murmur across the pulmonary area, ESM. And ostium primum ASD, as I told before, will be associated with incomplete RBB with left axis deviation. So, there will be a Q wave in lead 1 and AVL because of the counterclockwise deprioritization, and splintering of the S wave in lead 2, 3 AVF. The X-ray feature will be same like a ostium secundum ASD in ostium primum ASD with cleft anterior mitral leaflet wall. The mitral regurgitation will be predisposed to infective endocarditis, and because the blood from mitral regurgitation enters the LA and RA, there can be a V wave prominent in JVP. Next, how do you manage a case of atrial septal defect? The surgery is indicated if the pulmonary blood flow to the systemic circulation is more than 1.5:1. And the ideal age to operate is 2 to 4 years of age. Especially you have to operate before 25 years, and with the pulmonary artery systolic pressure less than 40 mm of Hg, you have to operate it. What are the contraindication to surgery? If there is a severe pulmonary hypertension, and if the pulmonary blood flow to systemic blood flow is less than 0.7 ratio, severe pulmonary vascular resistance increased with right to left shunt, and saturation less than 90%. So saturation less than 90%, severe pulmonary hypertension, irreversible pulmonary vascular resistance, and the pulmonary blood flow to systemic blood flow less than 0.7 is a contraindication to surgery in atrial septal defect. So this is about atrial septal defect, students. So to summarize, it is a left to right shunt lesion. Pulse will be normal, JAP will be normal unless they go for ECM angio. Auscultatory signs is wide fixed split S2, ESM across the pulmonary valve. ECG will show RBBB with right axis in secondum, RBBB with left axis in primum. X-ray will show pulmonary plethora and water jet appearance. And the indication of surgery is flow more than 1.5:1. Ideal age is 2 to 4 years of age. Thank you, students. So students, we have discussed the atrial septal defect case, the history taking, and the examination, the differential diagnosis. Now I want to show some of the syndromes, ECG and X-ray picture in atrial septal defect. So this is an ECG picture of atrial septal defect, students. So here, as I told, in a ostium secondum ASD, there will be a RBBB like this. Here in V1 you can see RBBB or R wave in V1, okay, indicating RBBB. And RBB, as I told, it is a misnomer because there is no any anatomical conduction block. Because of the RV enlargement and hypertrophy, there is a delay in the conduction. That is why you get a RBBB. And you see the axis here, students. Lead 1 is negative, AVF is positive, which indicates right axis deviation. So RBBB with the right axis deviation is a feature of OS, ostium secondum ASD, whereas RBBB with the left axis deviation is ostium secondum ASD. And ostium secondum ASD, as I told you, will have a crochetage, the notch in the 2-3 AVF, which I will show in the next ECG. See here, the notch in the lead 2, a notch in the AVF, even you get notch in the lead 3 also. These lead 2-3 AVF, there will be a notch which indicates crochetage. And then the depolarization in ostium secondum ASD is clockwise with a Q wave in lead 2-3 AVF. Lead 2-3 AVF, QS will be there. This is ostium primum ASD ECG, students. Here you can see RBBB, RSR dash pattern in V1. See the axis. AVF is negative and lead 1 is positive. AVF is negative. See here, AVF is negative. Lead 1 is positive. And RBBB. So RBBB with the left axis deviation indicates ostium primum ASD, students. And here there will be a counterclockwise depolarization with R wave in lead 2-3 AVF. See here, R wave in lead 2, lead 3 and AVF. Small R wave you can see here in AVF also. Here also in lead 2 and lead 3. The ECG in ostium, the ECG in sinus venosus ASD will be a absent PS in lead 2-3 AVF, students, because superior vena cava will go and attach to the atria where SA node is situated. There will be ectopic SA node which will produce the lead 2-3 AVF inverted P wave, students. So this is an X-ray picture of a atrial septal defect. Here you can see, students, there is a pulmonary plethora, and this is the right descending pulmonary artery which is enlarged here, right descending pulmonary artery enlarged because of the more blood flow entering the pulmonary artery. You can see that this is the water jug, the handle of a jug. It is the shape of a handle of a jug here, the pulmonary artery, which just go like this, comes like this, the handle of a water jug. So water jug appearance, students. And here you can see in this X-ray, students, there is a pulmonary plethora because of more blood flow, and aorta will be a inconspicuous in atrial septal defect because there is a less blood entering the aorta, students. So here you can make out right pulmonary artery, right atria which is enlarged, main pulmonary artery also which is enlarged in atrial septal defect because there is more blood to the pulmonary artery. From left atria to right atria blood enters, right atria to the pulmonary artery. So right pulmonary artery, main pulmonary artery is very prominent because more blood is entering from left atria through the shunt to the right atria and to the right ventricle. And this is the ECG picture of a Schmitter syndrome, students. So here the whole of the right pulmonary arteries will join together to join the inferior vena cava. See, this is the Turkish sword picture, okay, and they join the inferior vena cava. Ipsilateral lung can be hypoplastic with the cardia shifted toward the right side, and ipsilateral pulmonary artery can be hypoplastic. So Schmitter syndrome. This is a picture of a Turkish sword, and the pulmonary veins will join together to join the inferior vena cava. With the ipsilateral lung hypoplasia, that is why cardia is shifted towards the right side and right pulmonary artery will be hypoplastic. So some of the syndromes associated with the atrial septal defect students, Down syndrome, upslanting palpebral fissure. You can see the palpebral fissure is, the medial is down, the lateral part of the fissure is up, the slanted. The red arrow you can see slanted. Low set ears will be low set, short neck will be there, and nasal bridge will be flattened. Brush field spot, here you can make out the whitish, typically white spots arranged in the ring, brush field spots. And you can make out one skin fold of epicanthal fold, extra fold of skin which covers the inner corner of the eyes, epicanthal fold. So other characteristic features, single palmar crease student, single semi-increase, and the distance between the great toe and the second toe is increased here in phallus tetralogy. So this is Patavo syndrome where there will be a cleft lip and a cleft palate will be there, okay. And then there are microcephaly and holoprosencephaly where the forebrain fails to divide. And there will be a flexion deformity will be there, flexion deformity, and single palmar crease also will be there in Patavo syndrome along with the low set ears. So cleft lip, okay, and microcephaly will be there. Polydactyly is also a feature of Patavo syndrome. So this is Edwards syndrome where there is a micrognathia. You can see here micrognathia, small mouth and small jaw, and occipital protuberance. Occipital protuberance will be there along with a clenched fist. Fist will be clenched. Occipital protuberance and low set ears also they will have in Edwards syndrome. This is Ellis-Van-Creveld syndrome students where you can see they will have polydactyly, 6 fingers, polydactyly, sometimes clinodactyly where there will be a bent, syndactyly where the toes are, there is a webbing and joined together, and multiple frenulum. You can see 1, 2, 3, 4. Frenulum is multiple, and malformed incisor, maxillary incisors will be malformed, multiple frenulum. This Ellis-Van-Creveld syndrome will be associated with a common atrium. This is Oteram syndrome students where there is a hypoplasia of the radial bone and absence of a thumb. Here you can see there is no thumb at all, only fingers are there, and the radial hypoplasia, so short forearms is here, short forearms with the absent thumb and then a radial hypoplasia. See absent thumb here, you can make out only 4 fingers are there, Oteram syndrome, only 4 fingers. And triphalanx, see you can see in the thumb normally you will have 2 phalanx, but here you can see triphalanx. Okay, this is the metatarsal bone, this is the 1, 2, 3, 1, 2, 3, triphalanx, Oteram syndrome. Oteram syndrome, as I told, there can be absent thumb, there can be triphalanx of the thumb, and the difficulty in approximation of the thumb to the fingers, absent radius, phocomelia, abrachia, these are the features of Oteram syndrome. So all I acknowledge these diagrams to the Google web search students, both phallus tetralogy as well as atrial septal defect. And one more thing I want to tell in phallus tetralogy students, which I forgot to tell. Phallus tetralogy is a cyanotic heart disease, okay. So where there is decreased pulmonary blood flow. First you will divide the cyanotic heart disease phallus tetralogy into whether there is an increased pulmonary blood flow or reduced pulmonary blood flow. So the lesion with a decreased pulmonary blood flow is a phallus tetralogy because there is a pulmonary stenosis. And then next you will go whether RV dominance or LV dominance. Phallus tetralogy is a RV dominance, okay, because of the RV hypertrophy students. And the next approach you go whether there is a pulmonary hypertension present or not. In phallus tetralogy, pulmonary hypertension is not present students. So the 3 headings under which phallus tetralogy will be approached is whether there is an increased pulmonary blood flow or reduced pulmonary blood flow. So phallus tetralogy is a lesion with a reduced pulmonary blood flow. Next is whether RV dominance or LV dominance. So phallus tetralogy is a lesion with a RV dominance. And then whether pulmonary hypertension is present or not. In phallus tetralogy, pulmonary hypertension is not present. This is what given in Parla, which I forgot to tell in phallus tetralogy approach students. So that's why I am telling here. So just make a note of it. And all the diagrams I have taken both of VSD and phallus tetralogy from a Google web search. Thank you.